Hello, everyone, and welcome to our third screencast lecture on the cardiovascular system. Today, we're going to begin our discussion by taking a look at the cardiac cycle. So, when we use the term cardiac cycle, what are we referring to? Well, very simply, we're referring to uh, each heartbeat. So, each time your heart beats, that's referred to as one cardiac cycle. Now, whenever we look at the cardiac cycle itself, it actually has two distinct phases that we need to discuss. The first phase is referred to as systole. The second phase is referred to as diastole. Let's take a look at systole first and compare it and what the difference is between systole and diastole. So systole is the actual contraction phase of the heartbeat. So this is the time whenever the chambers of the heart are actually undergoing contraction. And so this would be both the atria and the ventricles, right? The four chambers of the heart. Though primarily we're going to be taking a look at the ventricles as we discuss systole. And the second phase is referred to, as I mentioned, as diastole. This is actually a relaxation phase. So this is the time when the chambers are not actively contracting. They're in a relaxed state and kind of recovering from the contraction and getting ready for another contraction to take place. So diastole then is going to refer to the relaxation of the chambers. Now, anytime we take a look at heartbeat, if you ever listen to the sounds of the heart whenever it undergoes the cardiac cycle, maybe you've auscultated, used a stethoscope to listen to the sounds of the heart, you know that there's this kind of lub-dub or lup-dup sound that you hear, these two sounds that are associated with the cardiac cycle. What are these two sounds? Well, let's kind of break it down. First of all, the lub sound, the first sound that we hear. This sound actually occurs. A lot of people think it's actually the sound of the heart wall undergoing contraction, but it's not. This actually occurs when increasing blood pressure inside the ventricles forces the atrioventricular valves to shut. So basically what happens is, you know, that blood is going to, let's take the left side of the heart, blood's going to return to the left side of the heart from the lungs. The blood is going to drain into the left atrium. From the left atrium, the blood's going to drain down into the left ventricle. Now the left ventricle is going to contract and it's going to push the blood back up toward the atria. As the pressure increases inside the left ventricle, the pressure that is created as the blood is forced back up is going to cause that atrioventricular valve, the mitral valve or the bicuspid valve, to snap shut to prevent the blood from going back up into the left atrium and to get the blood to eject out through the aorta, which is where we want it to go. So that sound of the snapping shut of the atrioventricular valve, and of course this is going to happen on the right side of the heart between the left ventricle the right ventricle and the right atrium and that tricuspid valve snapping shut. That sound is then the lub sound that we're referring to here, that first sound that we hear when we listen to the heartbeat. The second sound, we're going to call it dup. You can call it dub, whatever you want to call it, but it's the second sound. What causes this second sound to occur? Well, the second sound, the dup, occurs whenever the blood above the semilunar valves forces them to shut. So if we think about this, let's take the left ventricle again as our example. The left ventricle contracts, blood gets ejected out of the heart into the aorta. Now, when the ventricle relaxes, what's going to happen is gravitational forces are going to want to pull the blood back down into the ventricle. So as the weight of the blood kind of sits back down or moves back toward the ventricle, that aortic semilunar valve is going to snap shut to prevent the blood from coming back down into the heart. The sound we hear when those semilunar valves snap shut is the second sound, or the dup sound, that we're talking about here. Okay. Next up, what regulates or what controls the heartbeat? What causes the cardiac cycle to occur in the first place? Well, there are two forms of regulation associated with the heartbeat. There is what we call internal or intrinsic regulation. That means that this is control that's coming from within the wall of the heart itself. And there is what we call extrinsic or uh, external regulation. And that means that the regulation is coming from somewhere outside of the heart. Well, let's take a look at internal or intrinsic regulation first. Internal regulation begins with a specialized structure called the SA or sinoatrial node. This sinoatrial node is a specialized patch of tissue that has both muscular and nervous components to it, and therefore it's able to generate signals or action potentials. So as we move along, we're going to talk about the movement of the signal. When we talk about that, we're really talking about action potentials that are being formed here. So the sinoatrial node is located in the upper dorsal wall of the right atrium, top and dorsal a little bit more toward the back. The sinoatrial node is sometimes referred to as the heart's natural pacemaker because it is the sinoatrial node that is going to initiate the heartbeat or the cardiac cycle. Once the cardiac cycle is initiated, another important intrinsic regulatory structure is the AV node or atrioventricular node. This is a specialized patch of tissue that has both muscular and nervous components as well, so it's very similar in its organization to the SA node, but the AV node now is located at the base of the right atrium near the septum, that internal wall that divides the heart into right and left halves, you may recall. The job of the AV node is to collect up the signals from the SA node, bring them all back together again, and transfer those signals then to the next component of the intrinsic regulatory system, which is the AV bundle. So let's take a look at the AV bundle, the atrioventricular bundle. This is also known, by the way, as the bundle of His. It's actually pronounced His for the anatomist who first described it, but it looks like His, but it's actually pronounced His. The job of the AV bundle is to conduct the signal now for ventricular contraction from the AV node into structures called the bundle branches. And these bundle branches are located, these are processes or appendages, extensions that are located within the septal wall itself. There are two bundle branches, and the bundle branches, as we mentioned, will conduct the signal through the septum down to the apex of the heart, that conical tip of the heart. Eventually, the bundle branches will subdivide into a fine network of fibers which spread throughout the ventricles. This fine network of fibers is referred to as the Purkinje fibers. The Purkinje fibers then will allow the signals to shoot back out into the muscle tissue and stimulate contraction of the muscle fibers within the cardiac muscle tissue. This will cause the ventricles to contract, and they will contract from the apex back up toward the aorta and the pulmonary trunk so that the blood gets ejected properly from the heart. So here's a diagram that helps us understand this a little bit better. So here we can see at the top of the heart, here at the base of the heart, right? This broad portion is the base of the heart. This conical tip down here is the apex of the heart. So we have our sinoatrial node located in the upper dorsal wall of the right atrium. And the sinoatrial node generates action potentials which shoot out along these fibers and are released into the muscle tissue that's associated with the atria. So because the SA node is located here, The action potentials are generated at the top of the atria, spread out over the atria from top to bottom, and the atria sort of contract from top to bottom. And as they do that, what's going to happen? The right atrium is going to squeeze the blood down into the right ventricle. The left atrium is going to squeeze blood down into the left ventricle. Now, we do not want this signal to continue its top-down travel. Because if the signal traveled from top down and stimulated the ventricles to contract from top down, the ventricles would contract from the atria down toward the apex. And that would build pressure. There's no place for the blood to go. The tubes to carry blood out of the heart, the aorta and the pulmonary trunk, are located here and near the base of the heart. So we want the blood to be squeezed up and out of the heart. So we have to gather up the signal, and that's the job of the AV node. Notice how the fibers connected to the AV node. Gathers up the signal and then transfers the signal into the AV bundle. From the AV bundle into the bundle branches, and the bundle branches now will carry the signal down to the apex of the heart. And here we can see the branching then of the bundles, the AV bundles. Okay, and the fibers, the Purkinje fibers that branch off of the bundles, and the Purkinje fibers then will release the signal, the action potentials, into the heart muscle tissue, causing the fibers to contract. And now, instead of the fibers contracting from top down, the wall contracting from top down, the ventricles now will contract from bottom up. And that will push the blood up toward the aorta and the pulmonary trunk. So this is a very important signaling system to make sure that the heart beats correctly to push the blood as it should, not only throughout the heart, but also out into the main blood vessels. Okay, so now let's take a look at external or extrinsic regulation. Regulation of the heartbeat from somewhere else, from outside the heart itself. And external or extrinsic regulation is associated with the autonomic system, autonomic nervous system. It's the job of the autonomic nervous system. So external or extrinsic regulation is under autonomic control. Now recall that the autonomic nervous system has two branches, the sympathetic branch and the parasympathetic branch. Generally speaking, the sympathetic branch increases the activity of an organ while the parasympathetic branch decreases the activity of an organ. So the sympathetic nervous system with regard to the cardiac cycle will increase the activity of both the SA and the AV nodes. So the SA and AV nodes are responsible for signaling contraction to take place. The SA node generating the signals to cause the contractions to take place. But the question is, what if we need to increase or decrease the rate of the contractions to take place? Well, that's external or extrinsic regulation. So when the sympathetic nervous system signals the SA node will increase the rate at which it's signaling the chambers to contract, and along with that, the AV node. So what's going to happen? Under sympathetic influence, heartbeat is going to increase, or I guess I should say the heart rate is going to increase. Under parasympathetic control, signaling from the parasympathetic nervous system is actually going to decrease heart rate. Although I have to mention that it's not a one-to-one, it's not an on-off switch. So it's not like as if you want the heart rate to increase, you flip the switch to the sympathetic branch and heart rate increases, and if you want it to decrease, you flip the switch to the parasympathetic branch. In actuality, these two branches, the autonomic nervous system, signal the heart constantly. But what happens is, if we, in order for, let's say, for example, let me put it this way, In order for heartbeat to increase, two things has to happen. First, there has to be an increase in what we would call sympathetic tone, or signaling from the sympathetic branch of the autonomic nervous system. But at the same time, there has to be a decrease in parasympathetic tone, or signaling from the parasympathetic nervous system. So it's like you want to send out signals that say increase the heart, but you also want to decrease the signals that keep the heart beating slower to allow it to get faster. On the other hand, if you want the heart rate to slow down, you have to decrease sympathetic tone and increase parasympathetic tone. And whenever you do that, then the more you increase the parasympathetic tone and decrease the sympathetic tone, the slower the heart rate's going to get. As you increase sympathetic and decrease parasympathetic, the faster the heart rate is going to get. Got it? I hope that helps to understand that. Now, there's another component to extrinsic regulation or external regulation as well. It's not only heart rate is not only influenced by the autonomic nervous system, it's also influenced by hormones. And there are two hormones here primarily we talk about, and they are produced by the adrenal gland. These hormones are epinephrine and norepinephrine. And when released by the adrenal gland, they travel through the blood, and the SA and AV nodes have receptors, beta adrenergic receptors for these two hormones. When the hormones bind to the receptors on the SA node, let's say, for example, that's going to stimulate an increase in the activity of the SA node and cause the heart rate to increase. If the hormones are not present on the receptors, then the heart rate would decrease. So it's a combination of both autonomic control and hormonal control that regulates the rate at which the heart beats. Kind of works out like this. I'll give you this example. So during exercise, let's say, for example, I decide to get up out of my chair and go for a jog. Okay, what's going to happen? The muscles are going to have a higher demand for oxygen. The heart is going to have to adjust to keep up with that demand for oxygen. So the heart is going to begin to pump faster, and it's going to begin to pump a little stronger as well. This is going to occur due to sympathetic stimulation and the release of epinephrine and norepinephrine. Okay, so the two are going to kind of work together to regulate the heart rate. Okay, so here's just a diagram then that shows us external regulation. And on here, we can see in green, this is the parasympathetic branch of the autonomic nervous system. And remember, parasympathetic is what? Craniosacral, and this is coming out of the brain. So this nerve right here, which is the only nerve that works outside the head and neck. The wandering nerve, right, from Latin, the vagus nerve. So this is the vagus nerve, and see how the vagus nerve innervates both the sinoatrial node and the AV node. So stimulation from the parasympathetic branch is going to cause the AV node, and therefore the SA node and the AV node, to reduce their rate of signaling. The heart rate would slow down. The sympathetic branch, remember, is thoracolumbar. So here are several roots, and here is the sympathetic nerve branch coming down and innervating the sinoatrial and AV nodes. And remember, these are going to work together. Increase the sympathetic tone, decrease the parasympathetic tone. What's going to happen? Heart rate's going to increase. Increase the parasympathetic tone, decrease the sympathetic tone. What's going to happen? Heart rate is going to slow down. Throw into that mix epinephrine and norepinephrine. When they are present and bound to the receptors, they will cause an additional regulatory effect to increase the heart rate. So I hope that diagram helps you understand that a little bit better. Okay, so why are we taking a look at all this anatomy and physiology? Let's turn to a kind of a clinical example that shows us the importance of understanding all these things that we've just been learning about the heart. The clinical example I want to use is called cardiac output. What's cardiac output? That's the volume of blood that's pumped out of the heart per minute. And we can measure that, let's say, at the left ventricle or at the right ventricle, but typically it's going to be measured at the left ventricle. There are some symbols that we use clinically to represent the cardiac output, and those symbols are either CO or Q, though Q is more often used because CO can be confused with carbon monoxide. So then to determine the cardiac output, the Q is going to be equal to the heart rate times what we call the stroke volume. So we just discussed what the heart rate is, the number of times the heart beats per minute. What's the stroke volume, or SV? Well, stroke volume is defined as the amount of blood that's pumped out of the heart per beat. And again, we usually measure that at the left ventricle. And of course, when the heart beats, it will self-adjust, and unless there's some kind of a disease state, it'll self-adjust. So the output of the left ventricle is going to be matched by the output of the right ventricle. And that's why we say we usually associate it with the left ventricle. So the cardiac output then would be the heart rate times the amount of blood that's pumped out of, let's say, the left ventricle per beat. Okay. Now, to understand stroke volume a little bit more and understand the clinical importance of this, we have some important terms associated with stroke volume that I'd like for you to know and to understand. The first one is called EDV. The EDV stands for, I guess I should say, the end diastolic volume. The end diastolic volume, or EDV, is the amount of blood that fills the left ventricle during diastole, during the relaxation phase. Another term associated with stroke volume is ESV, or end systolic volume. The end systolic volume is the amount of blood that's going to remain in the left ventricle after it contracts and ejects out as much blood as it possibly can. So what's left in there is the end systolic volume. And then the final term associated with the stroke volume is called the ejection fraction, or the EF. The EF, or ejection fraction, is the percent of blood that's ejected by the left ventricle during systole. So let's take a look at a diagram to help us to understand how that works. So here's a diagram of the heart, and we'll focus here on the left side of the heart. Here's the left ventricle, and blood's going to be coming back into the left ventricle from the pulmonary veins. Remember, they're carrying the blood back from the lungs. It's highly oxygenated. This is oxygen-rich blood. As the oxygen-rich blood enters the left ventricle, it is immediately going to begin to start draining through this valve right here, the bicuspid or mitral valve, right? That's the AV valve between the left atrium and the left ventricle. So the blood naturally is going to drain down through here and begin to fill the left ventricle. Okay, now eventually what's going to happen is this atrium is going to contract, and it's going to squeeze any remaining blood, and that's usually somewhere around 25 to 30%. The last 25 to 30% of the blood will be squeezed with the atrial contraction down into the ventricle. Now the atria contracts before the ventricle does, so there's going to be this atrial contraction. We call it the atrial kick, and that's going to force the remaining blood down into the ventricle. The ventricle is still in a relaxed state. It's in diastole. But now that blood fills up that left ventricle. So there's the amount of blood. Let's say that amount of blood is 100 milliliters of blood that has filled that left ventricle. So that 100 milliliters of blood would be referred to as the EDV. That's going to be the volume of blood that's here in the left ventricle the instant before the left ventricle contracts or goes into systole. How much blood was there at the end of diastole for that left ventricle? Right at the instant before it starts to contract. So we say, to use round numbers, we're going to say that amount is 100 milliliters of blood. Okay, so what happens next? The signal travels down the bundle branches and now shoots into the muscle fibers from the Purkinje fibers, and the ventricle begins to contract from apex back up toward the base. As it does, it's going to increase pressure. That pressure is going to snap this valve shut, this atrioventricular valve, the mitral valve, the bicuspid valve, is going to snap shut, and that's going to divert the blood here up through this valve, the semilunar valve of the aorta. It'll pass through the semilunar valve and into the aorta. So there we can see blood has been ejected out. So how much blood has been ejected out? Well, let's say that the blood that has been ejected out, let's say that there is 30 milliliters of blood that remains here in the ventricle. And that's important to understand. When the ventricle contracts, even though it contracts and creates the force to force the blood out, not all the blood is going to come out. It's kind of like, whenever you have a drink out of a bottle of soda, or I have to keep my mouth dry here. I've got some LaCroix here, keep my mouth from drying up. But whenever I take a drink of this, even whenever I get to the end of the can, do I get all of the soda out of the can? Well, you can take the can and shake it, and there's still a little bit left. The same thing happens here when the ventricles contract. You're never going to get all the blood to come out of that ventricle. So there's always going to be a small amount of blood that's going to remain in the ventricle. And that blood that remains in the ventricle at the end of systole, so the instant the contraction stops, how much blood still remains? Because it's going to start to refill, but before it starts to refill, at the instant that systole ends, how much blood is still left in there? Well, let's say that 70 milliliters was ejected out. 70 from 100 leaves us with 30 milliliters of blood. That 30 milliliters of blood is referred to as the end systolic volume. Okay? Well, if the end systolic volume is 30 milliliters, what's the stroke volume? Well, obviously, it's 70 milliliters of blood. 70 milliliters of blood was ejected from that ventricle of the 100. 70 milliliters was ejected from the ventricle into the atrium. Now, by the way, when this ventricle relaxes and goes back into diastole, the blood's going to want to get, pulled back down. Gravitational force is going to want to pull the blood back down toward the ventricle. That's when this valve will snap shut, and we'll hear that second sound and stop the blood from going back down into the ventricle. But we're focused on that 70 milliliters of blood that was ejected out. That's the stroke volume. So how many times in a minute does this happen? Does it happen 60 times in a minute? Does it happen 70 times in a minute? 80 times in a minute? Multiply 70 milliliters times the number of times the heart beats per minute, and you've got the cardiac output. Now here's that third term that we talked about, which is the ejection fraction. So what would be the ejection fraction? Remember, that's the percentage of blood that was ejected during systole into the left ventricle. So we know that the amount of blood, that's the percentage, we know the amount of blood was 70 milliliters. 70 of 100 milliliters was ejected. So what's that fraction? That would be 70% of the blood was ejected. So the ejection fraction here would be 70%, which would be a high ejection fraction. Again, we're using just round numbers here. Actually, for a healthy heart, a good ejection fraction is somewhere around 55 to 60%. So 70% would be a little bit high on an ejection fraction. Okay. All right. Now, having understood stroke volume and the terms associated with stroke volume, let's go back to our discussion of cardiac output. So the average heart rate, and this is kind of what I was talking about earlier, is anywhere from 60 to 180 beats per minute. Now, no, I don't want you to sit there and think, what's he talking about? 60 to 180. We're not going to have, I'm not talking 180 beats per minute as you're just sitting there relaxed in your chair watching this video. Okay. It's going to be what, somewhere around 60 to 80 beats per minute. But when I talk 180 beats per minute, we're talking about whenever you get up and exercise. So from resting to exercise, it's going to be somewhere between, on average, 60 to 180 beats per minute. If the average stroke volume is, and this is a good average stroke volume, is around 70 milliliters, then at rest, and whenever the heart starts to beat faster and stronger, the stronger contraction can cause the stroke volume to increase to as much as 120 milliliters of blood per ejected into the aorta per beat of the heart. You follow that? Okay. If you don't, let me know in the discussion board. Anyway, so the cardiac output then is going to be between 4.2 liters, 60 beats per minute times 70 milliliters, going to give us about 4.2 liters of blood, to 21.6 liters of blood. So our cardiac output, maximum 180 beats per minute times 120 milliliters per beat, 21.6 liters. This brings us to the concept of cardiac reserve. So the cardiac reserve is the difference between the resting cardiac output and the maximum cardiac output. So the maximum cardiac output, 21.6, minus resting 4.2, 17.4 liters. What this is saying is that if you're at rest and you're putting out 4.2 liters of blood in your cardiac output, if you exercise or if you begin to do strenuous activity, you have the ability to increase the cardiac output by 17.4 liters over the course of a minute, if that makes sense. Okay, finally, I'd like to talk a little bit about some factors that can affect that stroke volume. So the stroke volume is the amount of blood that gets ejected again from the ventricle, and again, we'll look at the left ventricle, into the aorta. What I'm talking about here is what kind of factors can affect how much blood gets ejected into the aorta per heartbeat. Well, there are three important factors. The first is contractility, the contraction of the fibers, okay? And so the more fibers that contract, the stronger the force of the heartbeat's going to be. The more greater the force, the more blood's going to be ejected into the left ventricle. So let's say, for example, that an individual has multiple myocardial infarctions and they don't even know that they're having them. That's one of the things that can weaken the heart by killing or destroying fibers so they're not there to contract anymore. So now the heart wall can't contract with as much force because there are areas of dead tissue. And so without as much force, you're not going to be able to eject as much blood. The stroke volume is going to be a little bit lower. Another factor that can affect contractility is if the heart becomes enlarged. Oftentimes when that happens, the fibers become stiffened. And if the fibers become stiffened, they can't contract with as great a force, and that's going to reduce the stroke volume. Another factor that affects the stroke volume is the preload or the EDV. So by preload or when we look at the EDV, we're talking about how much blood fills the left ventricle during diastole right before it begins to contract. How much blood are we preloading into that ventricle? We talked about 100 milliliters, but what if the load increases to 120 milliliters of blood? Now we have a greater volume of blood in the ventricle. How is that going to affect stroke volume? Well, recall in the muscular system, we talked about something called Starling's law. And here we'll talk about Starling's law of the heart. It applies the same. For muscle tissue, when muscle tissue is when the fibers are pre-stretched, you recall we talked about this in the muscular system, pre-stretching the muscle fibers results in more forceful contraction of the muscle fibers. So the idea here is if we increase the load or the amount of blood that we load into the ventricle just prior to contraction, what that's going to do is that's going to cause a distension of the ventricle. So the ventricle is going to distend, and that's going to stretch the fibers that make up the wall of the ventricle. When those fibers are stretched, they're going to contract with greater force, and that's going to increase the stroke volume, the amount of blood that is going to be pumped out of the ventricle into either the aorta or the pulmonary trunk. And finally, another factor that affects stroke volume is the afterload. The afterload refers to the mean arterial pressure. So the mean arterial pressure is the average pressure in the blood vessels. Let's take the aorta, for example. So what's going to happen is when the ventricle contracts, the pressure is going to go up in the aorta, and then when the ventricle relaxes, the pressure is going to begin to fall off. So what's the average pressure that's in that blood vessel? That's the mean arterial pressure. And here's why that's important. As a matter of fact, I think we can go to this diagram again, okay? And it has to do with this valve right here. Let's take the aortic semilunar valve here. So what happens is when the ventricle contracts, it pushes the blood up into the aorta, and then the blood pushes or falls back down and pushes against this valve and causes it to snap shut. Now, this aorta is elastic, so it gives when the heart contracts, when the ventricle contracts, but then it snaps back to its original size when the ventricle relaxes. Well, as it snaps back, what that does is that maintains the pressure of the blood inside that vessel. Okay? And so the pressure is going to drop slowly back down to, let's say, 180, or excuse me, 80. So let's say that the pressure just prior to the next ventricular contraction is 80 millimeters of mercury. When this ventricle contracts and attempts to eject blood into the aorta another time, this valve will not open until the pressure from the ventricle pushing the blood out is greater than the pressure of the blood holding the valve shut. So that pressure has to, let's say, for example, if this is 80 millimeters of mercury, if that valve won't open until the ventricle generates enough force to be higher than 80 millimeters of mercury. Once the force is higher than 80 millimeters of mercury, the blood will eject into the atrium. Now, let's say, for example, a person has high blood pressure, and as a result of that high blood pressure, now their pressure here over the valve is 90 instead of 80. Okay? So if it's 90 instead of 80, you now have to overcome 90 millimeters of mercury to open up this valve. When this ventricle contracts, it's going to take longer to get to 90 millimeters of mercury. Okay? The longer it takes, when that valve finally does open and the blood ejects out, there's going to be less time to eject as much blood. So the stroke volume would be lower. Stroke volume would be higher if the pressure is only 80 millimeters of mercury, because that valve is going to open sooner. So more blood will be able to be ejected. So I hope that makes sense to everybody on how the afterload affects the stroke volume, the amount of blood that's pumped out per beat. Okay, now then we can take that one step further and talk clinically about heart failure, or more specifically, congestive heart failure. Congestive heart failure is the result of a decline in the pumping efficiency of the heart. This leads to inadequate circulation of blood. You're not going to get as much blood if the heart isn't pumping as efficiently. You're not going to get as much blood ejected from the heart. The ejection fraction is going to be lower, and you're going to have inadequate amounts of blood to circulate through the systemic system, let's say, for example. Heart failure, congestive heart failure, can be progressive. It can increase over time. It can also be due to coronary atherosclerosis, hardening of the coronary arteries and blockage of the coronary arteries. It can be due to high blood pressure. So the heart, if you have chronic high blood pressure, the heart has to work harder over time, and that can cause the heart wall to weaken and then not be able to eject as much blood as it normally would be able to. And of course, a history of multiple myocardial infarctions, not enough to actually stop the heart from beating, but enough to weaken the wall of the heart. That would decrease the pumping efficiency of the heart as well and lead to inadequate circulation. Now, we can actually divide this into what happens if it is the left side that fails to pump efficiently, or if it's the right side that fails to pump efficiently. Well, if the left side fails, this is going to lead to pulmonary congestion and potential suffocation of the patient. Okay, so here's the idea. If the left ventricle isn't pumping efficiently, and the right ventricle, due to a cardiomyopathy, some kind of disease of the heart wall where it's not able to keep up. Now, under normal circumstances, if the right side pumps out a little bit more blood, the left side will adjust and pump out a little bit more blood. But what happens when, let's say, that left side becomes weakened and can't adjust to the right side? So it can't pump out as much blood as the right side can. So the right side pumps out blood. The blood goes where? Goes to the lungs, becomes oxygenated. Via the pulmonary veins, it comes back to the left side of the heart. Blood straining into the left side of the heart. Okay, now the right side is, let's say, pumping out 100 milliliters, and the left side is pumping out 100 milliliters. We've got no problems. But what if the right side is pumping out 100 milliliters and the left side now, due to a weakening of the heart wall, is pumping out only 50 milliliters of blood? Not as much blood is getting ejected. Blood is remaining in the ventricle now. Okay? And the blood that's remaining in the ventricle, as new blood, as more blood is continuing to drain in, there's not as much room. You can only fill the jar up so full. There's not as much room, so pressure begins to build in the atrium as the blood can't drain from the atrium into the ventricle. If the blood can't drain from the atrium, now the blood from the pulmonary veins can't drain into the atrium as easily, and the blood begins to back up in the pulmonary veins, and this progresses all the way back to the lungs. So what happens? Back at the level of the lungs, the blood pressure in the capillary beds increases. This causes, if we think about capillary exchange, this causes more water to be squirted out of the blood vessel and into the tissue around the lungs. And because the pressure is higher, we can't overcome osmotic pressure as easily, so the water doesn't get recovered as quickly. So less water gets recovered, more water remains in those tissues, and eventually the water can move from the tissues, the pressure builds up in the tissues, and can push the water back into the alveoli of the lungs. And the alveoli of the lungs then begin to get water in them. Some symptoms of that, people begin to cough, they have trouble breathing, and if this continues, it can lead to suffocation because that's going to limit the ability for oxygen exchange to take place. However, if the right side fails, this is now the left side is pumping normally. The right side is not. It's failing to pump out as much blood as it would normally be able to. So what happens? Now we get pressure starting to build up in the systemic system back toward the tissues. It affects capillary exchange, and we get peripheral congestion and edema. We get swelling in the legs. We get swelling throughout the body, the lower extremities, the upper extremities. The liver can become swollen, and that can be painful. And that's because, again, water exchange isn't working properly. You should have a certain amount of water getting out, and then under normal pressures, the water gets recovered. But now the higher pressure causes more water to be squirted out and less water to be recovered. So the water remains in the tissues. The tissues become saturated with water. They become inflamed, or edema sets in. Okay, you get all this extra water and swelling in the peripheral tissues. Okay, so that's a little bit about congestive heart failure, and that kind of helps us to put everything together. If you're still having trouble and struggling with that, here's a good video that I posted on Canvas on video under videos and animations that can help you understand better some more features of cardiac or congestive heart failure. So just take a look at this video, and I think it'll help you. Okay, next up, we want to turn our attention to the electrocardiogram. The ECG or EKG. What's an electrocardiogram? It's a record of the electrical activity of the heart that causes contraction and relaxation of the atria and ventricles during the cardiac cycle. So this is going to be associated with the intrinsic regulatory system. So an EKG is inscribed on a ruled piece of paper like we see here in our diagram. Looking at these electrical changes can allow doctors to detect abnormalities, so you should know some basics on an EKG or an ECG. Let's talk about, first of all, the basic components. And this is not the end-all be-all. These are just the basic components of an EKG. First, we have the isoelectric line. This is a baseline, and it's flat when there's no electrical activity that is present in the heart. However, if there is electrical activity present in the heart, next up we'll see what we call a P wave. The P wave is the first upward deflection of the isoelectric line. It represents the contraction of the atria. So this is when the SA node is going to shoot out that signal, the action potentials, and the atria are going to contract, and that's going to cause that first upward deflection of the isoelectric line we call the P wave. Next, we have the QRS wave. The QRS wave represents contraction of the ventricles. When the ventricles contract, they're lined with much more muscle tissue, cardiac muscle tissue, and so the contractions are going to be much more forceful, So the QRS waves are going to be taller on the EKG. Next up, we have the T wave. The T wave represents the time during which the ventricles are preparing for another contraction. They're sort of going through the repolarization process there. Okay, and then finally we have the ST segment. I think is a basic component that you should be familiar with. The ST segment is a flat piece of baseline between the end of the S wave and the beginning of the T wave. So it runs from the end of the S to the beginning of the T. That's why it's referred to as the ST segment. Okay, let's take a look at these on a typical ECG or EKG. So here is our isoelectric line. Whoops. Let's just go back here. Sorry about that. Here's our isoelectric line. Here's our first deflection of the isoelectric line, the P wave. Then there's a short segment here. And then our QRS complex or QRS wave, the contraction of the ventricles. Then our ST segment, another piece of flat line, isoelectric line. And then we have our next deflection of the isoelectric line, the T wave, represents repolarization of the ventricles. And then we're off to the next cardiac cycle. So in this slide, we can kind of show you what's being represented here. So in number one, here we have atrial depolarization begins. So we see the P wave with atrial depolarization. By the time we get to 2, where this little flat line is, the depolarization is over. Okay, so we don't have a bump or a lump there because we're back to the flat line again. So atrial depolarization is complete. Now at 3, this QRS complex right here, we see this large wave, is going to represent the time during which ventricular depolarization is going to begin. Now also at this time, the atria are going to repolarize. Do we see a little bump for the atria? No. What we find is the little bump where the atria are repolarizing is going to be masked by this depolarization deflection from the depolarization of the ventricles. Okay, we get to number 4 then. The ventricular depolarization is now complete, and we're back to the baseline again. So we have this piece of flat baseline, that's the ST segment. Now what's going to happen is the ventricles are going to repolarize. That means that we're going to get all of the ions back into their original positions, right, where we have positive outside and negative inside along the surface of the cardiac muscle fibers. So while we're getting that repolarization to occur, we have this next upward deflection, which is the T wave. And then at number 6 here, ventricular repolarization is complete, and we're back to the flat line, and we're ready to begin a new cardiac cycle. Okay, why is that important to understand the basics of the ECG? Well, abnormalities can help doctors diagnose disease and what's going on with the heart. So let's take a look at some abnormalities from these basics that we might see. So we might see a missing P wave. If the P wave is missing, that means the sinoatrial node is diseased and not signaling the contraction of the atria. So in other words, instead of getting that atrial kick at the end, the blood's just going to drain from the atria down into the ventricles. Number 2, another abnormality we can see is if the QRS complex takes too long or has more than one peak. That indicates a bundle branch block. Something is interrupting or impeding the transmission of the signal or the impulse along the AV bundle down to the apex of the heart. So that means that because it's taking longer, there's going to be a delay in the actual contraction of the ventricles. An inverted T wave. So instead of the T wave being deflected upward, It could be deflected downward. That would be an inverted T. Can indicate ischemia, insufficient blood flow into the cardiac muscle tissue, insufficient perfusion of blood in the cardiac muscle tissue. And this can lead to, an inverted T can lead to myocardial infarction. So if you're not getting enough blood into the muscle tissue, it's not getting oxygenated, it's not getting nutrients the way it should, the tissue could eventually die. That would be called a myocardial infarction, a death of myocardial muscle tissue of the heart wall. And that's one of the many causes of a heart attack. And then finally, we have an uncoordinated or irregular QRS complex. This is going to indicate what we call ventricular fibrillation. So instead of the ventricles contracting nice and forcefully the way they should, they're kind of quivering. And as a result of that, because they're quivering, we're going to have insufficient ejection of blood into the aorta and the pulmonary trunk, and that's going to lead to insufficient perfusion of the tissues and can result in sudden cardiac death, sudden stoppage of the heart, and death of the individual. So let's look at some examples of these. Here is a 3-second, 3-second strips from an EKG sample. And what do we see here? Got any ideas of any abnormalities we may see? Well, we do see P wave here, but look at this. We see multiple P waves. This is an example of AFib. Now, there's something that's very similar to AFib, atrial fibrillation. And by the way, in atrial fibrillation, what's happening is the atria, instead of not contracting at all, like with a missing P, they're contracting, but they're just quivering. They're not getting good forceful contractions. So they're fibrillating. Okay, so we're seeing these multiple peaks here as they're quivering. There's something very similar to this that we see, which is called atrial flutter. But with atrial flutter, this one kind of looks very similar. Atrial flutter, these P waves would be more like a saw blade tip. But the reason why, and this could be very difficult to tell the difference here, but the reason why I look at this and say this is AFib is because we can see that the distance between the QRS complexes, or when the ventricles contract, is not regular. It's kind of rhythmic, and so we have a long time between ventricular contractions, a longer time, then a shorter time, then an even shorter time. We don't have regular ventricular contraction, and that happens in AFib. All right, what about this one? Well, if we look at this one, we're not seeing any kind of coordinated contraction of the heart at all. This is an example of ventricular fibrillation, VFib, on this diagram. And what about this one? So if we take a look here, we actually have two leads that we're taking a look at here. And what we can see here is that, look at our QRS complex. Instead of there being one sharp up and then down and back to the flat line, we can see there are two peaks here. There's a first peak there, and then we have a second peak here. What's happening here is the signal from the bundle branches is not getting to the ventricles at the same time. So there's a bundle branch block. Now in this one over here, if we take a look at this, we can see the QRS complex kind of has a W shape to it. Okay, when the QRS complex has twin peaks and it kind of looks like a W, that indicates a right bundle branch block. So the blockage is in the right bundle branch. On the other hand, if we look at this one over here, we can see that we do have twin peaks again, but in this case, the QRS complex looks more like an M than it does a W. When it looks more like an M than a W, That's a left bundle branch block. That indicates to us that there's something impeding the movement of the action potentials down the left bundle branch. Okay. We also note here that there's inverted T waves here. Um, and so inverted T waves can indicate ischemia um, because we're maybe not getting adequate contraction of the ventricles um, to provide enough blood perfusion to the cardiac muscle tissue. And then finally, on this EKG, what we're seeing here is we see very short distances between the QRS complexes. So the shorter the distance is, the faster the heart rate is going to be. So we have the cardiac cycle occurring very, very rapidly. This is an example of tachycardia. As a matter of fact, this one actually kind of looks like supraventricular tachycardia. In other words, the ventricles are contracting very, very rapidly, and supraventricular means that it's something that's going on above the ventricles that's causing that rapid heart rate. This is so rapid here that we can see that normally we'd think we should see a P wave, then a QRS, then a T wave, then a P wave. These are so rapid that the P waves and the T waves are indistinguishable from one another. Okay, so it's a very rapid heart rate. This would be supraventricular tachycardia. So those are some examples of how the EKG is important in helping us to detect heart abnormalities. Okay, let's turn our attention now to wrapping things up and talk a little bit about blood pressure. So blood pressure is the pressure of the blood against the wall of the blood vessel. So when the ventricles contract and eject the blood resists moving through that vessel, and it pushes up against the wall of the vessel and creates pressure. That pressure is blood pressure. We use an instrument to measure blood pressure. That instrument is called a sphygmomanometer. When we talk about blood pressure, we have two numbers associated with blood pressure, right? The first one is the systolic blood pressure. That's the pressure in the arteries when the heart ventricles are contracting. So when the ventricle contracts and pushes the blood into the artery, the pressure inside the artery is going to go up to a peak. That peak, when the ventricles are contracting, is called the systolic blood pressure. Diastolic blood pressure, on the other hand, is the pressure in the arteries when the heart ventricles are refilling. So now the ventricle contracts, pushes the blood out. Now the ventricle relaxes and begins to refill with blood. So now what happens is the blood pressure is going to start to drop back down, and drop until the ventricle contracts again, and it'll go up. That low point that it drops to right before the ventricle contracts again is the diastolic blood pressure. So the average blood pressure is recorded, and this would be for a normal 30-year-old healthy individual, would be 120/80. Although don't think if I don't have 120/80, there must be something wrong with me. That could be adjusted for gender, male versus female, height and weight. All these will be factors that would play into the blood pressure. Blood pressure is important for us to note, and I think we have when we were talking about capillary exchange, does decrease with distance from the left ventricle. So the further you get away from the pumping source, the lower the pressure is going to be. And remember, blood pressure is controlled by the arterioles, as we mentioned, because of those sphincter muscles and because of autonomic control over dilation and constriction of the lumen of the blood vessel. Here's the latest guidelines as far as blood pressure is concerned. The guidelines were recently changed. Sorry about that. I got a phone call in the middle of our presentation here. But this is just the recent guidelines from the American Heart Association with regard to blood pressure and the different categories: normal, elevated, high hypertension stage 1, stage 2, and crisis, and what the numbers are. So I put that up there for your review. You can refer to Canvas under extending your knowledge for the new blood pressure guidelines and for more information. I have some further information there on Canvas. Okay, next up, let's talk about blood flow and the rate of blood flow. So blood flow in the capillaries is going to be slow, and that makes sense, right? Because that's where capillary exchange is going to take place. And that slower blood flow is going to allow for the exchange of substances between the blood and the surrounding tissues to occur. But as the blood moves from the capillaries back into the veins, blood flow is going to increase again. There are three factors that are going to have an effect on blood flow in the veins and help with this increase. The first is skeletal muscle contraction. So in the veins, as we, let's say, for example, walk around or move around, the veins are deep, so the muscles will kind of massage blood in the veins, and that massaging will help to not only increase the flow, but also provide additional force to move the blood back toward the heart. Breathing is another factor that also affects the venous return, the flow of blood back into the heart. So blood will flow from higher pressure to lower pressure. So every time we inhale, the chest cavity increases in size, and we'll talk about that more when we get into the respiratory system. So with that increase in size, the pressure inside the chest cavity goes down, it falls, and whenever we exhale, the chest cavity decreases in size, and so the pressure goes up again. So this creates a kind of a fluctuation in pressures that helps to drive blood back toward the heart. And then, of course, there are the valves, which we've already talked about. Remember, the valves in the extremities, in the larger veins. Let's say, for example, in our legs, whenever the pressure goes up from a heart contraction, ventricular contraction, the valve is going to open, blood's going to pass up through that valve, and then gravity, when the heart relaxes, is going to want to pull it back down again. So these valves are in our legs. They snap shut, the blood hits against the valve and can't go back from whence it came, for example. So the blood remains there, and with the next contraction of the heart, the blood goes up to the next valve, and then that valve closes and stops the blood from coming back down. So valves help with venous return as well. A little bit on blood circuits. So when we talk about how blood circulates through the body, we have two main circuits. The first is called the pulmonary circuit. The pulmonary circuit transports deoxygenated blood from the heart into the lungs. It also transports oxygenated blood from the lungs back to the left atrium. So the pulmonary circuit runs from the heart, the right side of the heart, to the lungs, and from the lungs back to the left side of the heart. That completes the pulmonary circuit. So here's the pulmonary circuit laid out. Blood gets ejected into the pulmonary trunk from the right ventricle. From the pulmonary trunk, the blood travels into the right and left pulmonary arteries. And the right and left pulmonary arteries carry the blood to the right and left lungs, becomes oxygenated in the capillary beds. Capillary beds form tributaries to back to the venules. The venules form into the pulmonary veins. So we have the right and left pulmonary veins carrying blood back from the right and left lung respectively, and that blood is then deposited into the left atrium to complete the pulmonary circuit. The second main circuit we have is the systemic circuit. Systemic circuit transports blood from the heart to the tissues and the cells, and then back to the heart again. The aorta is the largest artery. It's going to begin the systemic circuit. It's going to receive blood from the left ventricle. and we've been talking about that. So blood exits the left ventricle into the aorta. The aorta gives off branches of arteries that allow the blood to pass out to the different areas and tissues of the body. Forms the capillary beds. The capillary beds form the venules. The venules form the smaller veins. Eventually, those smaller veins bring blood back to either the superior or inferior vena cava. These are the largest of the veins, and they return the blood back to the heart. The superior vena cava, by the way, collects blood from the head, chest, and upper extremities, while the inferior vena cava is going to collect blood from the lower extremities and the abdominopelvic regions and return it to the right atrium of the heart. A subdivision of the systemic circuit that we can talk about is coronary circulation. We've kind of already gone over that. Coronary circulation transports blood through the myocardium of the heart, through the muscular wall of the heart. Another subdivision of the systemic circuit is the hepatic portal system. The hepatic portal system takes blood from the organs of digestion to the liver through the hepatic portal vein. Hepatic, IC, means pertaining to. Hepata means liver. So this hepatic portal vein is going to carry the blood from any of the organs of digestion to the liver and allow materials in the blood to be processed by the liver. So in regards to that, the blood coming back into the liver, nutrients and toxins can be absorbed from the blood into the liver, and then they can be either excreted or converted into other substances in the liver. So here's a diagram then showing the hepatic portal system. It's in yellow. So we can see the hepatic portal system has veins associated with the spleen, the pancreas, the stomach, the duodenum, all the components of the small intestine, and the colon, parts of the large intestine as well. So anything that's going to be coming out in exchange from these areas is going to be transported into this one large hepatic portal vein, which is going to deliver the blood into the liver for processing. All right, very quickly here, some cardiovascular disorders. Hypertension, we've already talked about. High blood pressure. Hypertension is high blood pressure. It's going to result when blood moves through vessels at a rate higher than normal, and that's often due to the buildup of arterial plaque in the blood vessel. 140/90 is considered hypertension, but you can refer to the chart that we talked about earlier for more detailed understanding of hypertension. The problem for hypertension is it's a very silent killer because there are very few symptoms of hypertension. So it's hard to know unless you're monitoring your blood pressure when you have hypertension. But it's very important to know your blood pressure because it can lead to heart attacks, stroke, heart failure, kidney failure, so on and so forth. Next up, we have atherosclerosis, and atherosclerosis is a form of arteriosclerosis. So arteriosclerosis is a hardening and narrowing of the arteries. If that hardening and narrowing of the arteries is due to plaque buildup in the vessels, then that form of arteriosclerosis is called atherosclerosis. By the way, plaque is a collection of fat, cholesterol, calcium, and other substances on the tunica intima of the arteries, which causes a narrowing of the lumen of the artery. Also associated with this, we should talk about a thrombus. A thrombus is a blood clot that forms inside a blood vessel or inside the cavity of the heart. And that is distinguished from an embolism. An embolism is a detached intravascular mass, which is capable of clogging capillary beds far from the site of origin. So one of the things that could happen is you could have a thrombus, let's say, form in a vein in the leg. you might say a deep vein thrombosis, and a portion of that clot could tear away. That's the problem with DVTs. Could tear away and now travel through the bloodstream to the brain, to the lungs, and clog capillary beds in the brain or the lungs. Since it traveled from another site, that detached intravascular mass, which could be a blood clot, is now referred to as an embolism. So if you have a pulmonary embolism, it is a clogging of the capillary beds from an intravascular mass that forms somewhere else in the tissues or in the body. Either of those and atherosclerosis are associated with stroke, heart attack, and aneurysms, and that's why they're important. This is just a diagram that shows a coronary artery, and here is an open coronary artery, and here is one with plaque buildup on the wall of the intima. So we can see the plaque buildup here, okay? And that's going to occlude or narrow the opening to allow blood flow through that capillary lumen. Our next cardiovascular disorder is stroke. Strokes clinically are known as cerebrovascular accidents or CVAs. These usually occur when a cranial artery becomes blocked or when it bursts, and that's going to result in part of the brain dying due to a lack of oxygen. The symptoms of a stroke may include numbness in the hands or face, difficulty speaking, inability to see in one eye. It all depends on where the stroke occurs on the brain at. Next cardiovascular disorder is a heart attack. Heart attacks are also known as myocardial infarctions, or actually one type of heart attack. And here, a part of the heart dies due to a lack of oxygen. That is in a myocardial infarction. Symptoms can begin with angina pectoris, a pain that radiates down the left arm due to a blockage of a coronary artery. And so what's happening is the brain is misinterpreting the damage to the heart as coming from the left arm and from the chest area. And so that pain radiating down the left arm is due to the brain misinterpreting where the damaged tissue is. It's called referred pain. Maybe you learned about referred pain when you looked at the autonomic nervous system. Our next cardiovascular disorder is an aneurysm. An aneurysm is defined as a ballooning of a blood vessel. Most commonly affected vessels are the abdominal aorta or the arteries that lead into the various areas of the brain. Atherosclerosis and hypertension can cause a weakening of the blood vessel, and that's what causes it to balloon and eventually could rupture and lead to a stroke. So we take a look at some preventable risk factors for these cardiovascular disorders. These are things that you can do something about. Use of tobacco products, drug and alcohol abuse, obesity and a sedentary lifestyle, having a poor diet, chronic stress, I should stipulate there, and poor dental hygiene. You know, people look at poor dental hygiene and say, how does that have to do with some of these cardiovascular? How can that cause a stroke or a myocardial infarction? Well, poor dental hygiene can lead to, let's say, for example, cracking of the gums and bleeding, which can open up a portal of entry for bacteria to get into and other germs to get into the blood and cause damage to the blood vessels. So it is very important to have good dental hygiene. Okay, so that concludes our cardiovascular system lecture screencast 3. Have a great day, and we'll see you next time.